My name is Adrienn Kéri. As well as I'm a PhD student, I'm also a third-year pediatric resident at the Heim Translational Pediatric Insitute. I'm not only interested in the science of cystic fibrosis, but I'm also involved in the medical care of patients with cystic fibrosis under the guidance of my supervisor, Andrea. Therefore, my vision is to improve the life quality and extend the life expectancy of cystic fibrosis patients with better clinical assessment. How would I like to achieve it? By applying up-to-date scientific results in the clinical assessment of cystic fibrosis-related glucose abnormalities. When I started to work at the Heim Hospital and before I met children with cystic fibrosis, I thought that the medieval prophecy will come alive. Who the child who tastes salty from a kiss on the brow, for he is cursed and soon will die. Because we have all learned in the university that this is the most common autosomal recessive disorder. It's a life-shortening disease that affects multiple organs. So I expected something like this, like on the picture. Like in the 50s, a malnourished child with severe ascites and several lung infections. But fortunately, that wasn't the case. Life expectancy in cystic fibrosis increased in the past decades thanks to new therapeutic options. Therefore, complications that need time to evolve, such as osteoporosis or cystic fibrosis-related diabetes, has come to light. If we would like to improve the medical care of these patients, nowadays it's not enough to concentrate on the symptoms we did so far. We have to examine the complications, the new ones. That's why we are conducting a meta-analysis and cohort analysis in the topic of cystic fibrosis-related glucose abnormalities. The meta-analysis is about the prevalence of abnormal glucose tolerance in patients with cystic fibrosis. By the age of 40, approximately half of the patients have cystic fibrosis-related diabetes. But if we think about abnormal glucose tolerance as a spectrum disease, where at the end there is diabetes, but before that there are prediabetic conditions, such as impaired glucose tolerance or even fasting glucose. And basic scientific results suggest that this prediabetic condition starts at early ages in cystic fibrosis. But despite that fact, oral glucose tolerance test, which is the gold standard method for diagnosing abnormal glucose tolerance in patients with cystic fibrosis, is recommended only from the age of 10. And therefore, characteristics and dynamics of the progression in the abnormal glucose tolerance status is still unclear. With our meta-analysis, we will assess what is the prevalence of abnormal glucose tolerance in different age groups of cystic fibrosis. We hypothesize that abnormal glucose tolerance is more prevalent under the age of 10 in patients with cystic fibrosis compared to healthy population. If we can prove our hypothesis, it could be the basis to reconsider the current guidelines and move the OGTT to a younger age. And if we can fight abnormal glucose tolerance and we can treat abnormal glucose tolerance as early as possible, we can delay the onset of diabetes and prevent all the consequences of an untreated diabetes. We conducted the systematic search in 3 databases with the following search key. With this search key, we found approximately 13,000 hits, and after the duplicate removal and the title and abstract selection, we went down to 1,200 eligible articles, and now we are at the full text selection phase. The meta-analysis will provide a clear picture about the prevalence of glucose abnormalities related to cystic fibrosis, but it won't answer further questions, such as what if there is this predisposing factor for cystic fibrosis-related glucose abnormalities, or how does the abnormal glucose tolerance spectrum evolve by time? By analyzing the data of an ongoing registry, the Cystic Fibrosis-related Pancreatic Disorder Registry, we intend to answer these questions. We will assess the prevalence of abnormal glucose tolerance in our registry patients, especially under the age of 10. We hypothesize the same as our previous project. And if we can treat abnormal glucose tolerance as early as possible in our patients as well, it will prevent all the consequences. But the registry has 2 main advantages. First is on a huge biobank, which collects biosamples, blood, feces, saliva. By investigating these biosamples, we will have the possibility to identify biomarkers as early predictors of abnormal glucose tolerance. And the other advantage of the registry, it's an ongoing registry since 2019, and it has yearly follow-up visits. By gaining yearly results about the abnormal glucose tolerance, we will have the chance to earn knowledge about the dynamics of the progression in the abnormal glucose tolerance status. The registry supports wider use, so not all the 91 patients will be eligible for us. Only 82 patients will be eligible whom are able to undergo OGTT or who were previously diagnosed with diabetes or whom were under 18 when they were involved. On the diagram, you can see the yearly changes in the patient number, and as you can see, approximately half of them has 2-year follow-up, 15 of them has 1-year follow-up, and it will provide us sufficient data to gain knowledge about the progression in the abnormal glucose tolerance statuses. I hope I could show you that the correct management of cystic fibrosis-related glucose abnormalities can improve the life quality of patients with cystic fibrosis. And our aim with these 2 studies is to take a role in this mission. But as Winston Churchill once said, however beautiful the strategy, you should occasionally look at the results. So that's why we will look at the preliminary results as well, not just the final ones. Thank you for your attention.
What other markers do you expect to find that could predict the impaired glucose tolerance? And you also mentioned that you want to avoid the diabetes or try to avoid it. Do we have, or how can we prevent if we identify the groups that are at risk?
Thank you for your question. To answer the first one, we will investigate microRNA particles or one fatty acid is, it could be the biomarker for the predictor. It's alpha-hydroxybutyrate, and it was investigated in insulin resistance as well. And to answer your second question, which was about the treatment, if you can diagnose, for example, impaired glucose tolerance, you can start a native glucose-free diet for a cystic fibrosis patient, and it will delay the onset of the diabetes, as for insulin-resistant people.
So C-peptide can be a marker as well?
Yes, also it could be, and different transformation variants of C-peptide could be a predictor.
Are you planning to follow these patients in adulthood as well?
Yes, if they were involved in under 18, then we will carry on if they go to the adulthood.
And do you already have a patient above the age of 18 in the registry?
Yes, we have, but he was involved in 2019.
And how old is he?
Excuse me?
How old is he?
I think he's 20 now, 21.
Okay. So he's the oldest patient as an adult?
I guess, yes.
Okay. Thank you.
I have 2 questions regarding your presentation. One is that are you looking at other risk factors for diabetes when you're looking at your registry or filling out data such as exercise or diet? And the other question is, are you looking at family traits, if there was any predisposition apart from CF?
To answer your first one, we will look at any other risk factors. So genotype could be a risk factor, and we will investigate it. Or family history, as you mentioned, could be a risk factor. So presence of any kind of diabetes, or diabetes type 1 or type 2 could be a predisposal factor for early onset of cystic fibrosis-related glucose abnormalities.
Thank you.
I have a question regarding your second project regarding the follow-up of the patients. It is not, if you go back to the PICO or PEOO, you are talking about the general population, and you are saying that you will follow actually patients with already cystic fibrosis, as I understand. Yes. You will have also a control then, or what does that mean that in the P you have general population and you want to...
We would like to compare their results to the healthy population, which means the WHO results of abnormal glucose tolerance prevalence.
You don't plan to actually follow up patients without cystic fibrosis and see the prevalence in those patients as well and compare like that?
We haven't planned it yet, but it could be the case.